Jennifer. Good morning. It's my pleasure for you to update you on the data we will present later this morning on the impact of stromal tumor-infiltrating lymphocyte, or TILs, in the context of patients with early-stage HER2-positive breast cancer who were treated with either chemotherapy alone or chemotherapy in combination with trastuzumab. Some background. Stromal tumor-infiltrating lymphocytes have been reported to be prognostic after patients receive chemotherapy for triple-negative breast cancer. In other words, if patients have increasing amounts of tumor-infiltrating lymphocytes, these patients with triple-negative breast cancer do better after chemotherapy. In the setting of HER2-positive early-stage breast cancer, there was a report earlier this year that included a small number of patients, 209 patients, with a total of 49 recurrence events in the context of the FIN-HER adjuvant trial, which was chemotherapy versus chemotherapy plus 9 weeks of trastuzumab, in which the investigators concluded, and I quote, higher levels of stromal TILs are associated with increased trastuzumab benefit. Thus, we sought to evaluate the potential prognostic and predictive association of stromal TILs with outcome in almost 1,000 patients with early-stage HER2-positive breast cancer who participated in the N9831 clinical trial, which again looked at chemotherapy versus chemotherapy plus trastuzumab. So the patient numbers and events in our study is essentially four times the numbers that have been reported based on the small FIN-HER clinical study. Methods. Stromal TILs were evaluated using what we have now as consensus guidelines internationally, in which we evaluated the presence of these cells using hematoxylin and eosin. The cases were reviewed by single pathologists, but 10% of the cases were read by 2 pathologists in tandem. After that, we had about 10% of the cases read by an additional pathologist so that we could corroborate concordance amongst the readings amongst the 3 pathologists. We defined the stromal tumor-infiltrating lymphocytes, again, based on these international guidelines that we had been part of developing and publishing earlier this year. In terms of measurements of stromal TILs for our presentation, we had 2 ways to measure TILs. One, we measured TILs based on whether the tumors had 60 or greater % of TILs, and that were classified as lymphocyte predominant breast cancer, LPBC. So if the tumors had less than 60% infiltration with TILs, they were non-lymphocytic predominant. We also looked at TIL measurements based on these deciles, in other words, from 1 to 10, 11 to 20, and so on, to see if any of these 2 parameters correlated with patient outcome. Here is the distribution of stromal TILs for each of the separate arms of the study and the entire group. And as you see here, for the total of almost 1,000 patients we enrolled, a total of 945 patients. Look at the deciles here by percentage. The majority of these patients with early-stage HER2-positive breast cancer had low levels of tumor-infiltrating lymphocytes. But as you see in the bottom part of this table, approximately 10% of the patients had tumors that were highly infiltrated with lymphocytes. As you see, LP, or lymphocyte predominant, as you see, 9% or between 9 to 10% for the total group of patients, and similar numbers for each one of the 2 treatment arms. Arm A was chemotherapy alone, Arm C chemotherapy in combination with trastuzumab. Now let's start getting a glimpse of the results. We looked at the association of lymphocyte predominant breast cancer in the context of the treatment arms that the patients received. So on the left panel, I have the outcome of patients who received Arm A or chemotherapy alone. And as you see, the patients who had lymphocyte predominant breast cancer had much better outcome to chemotherapy alone compared to patients who had non-lymphocyte predominant breast cancer, and this was statistically significant. A finding, however, that surprised us is that when we analyzed the data for patients who received what we now consider to be standard of care, chemotherapy in combination with trastuzumab, if these tumors were highly infiltrated with lymphocytes, there was actually no statistical difference in outcome. If the patients received chemotherapy trastuzumab if the tumor had high lymphocytic infiltration or if the tumors did not have high lymphocytic infiltration. So lymphocytic infiltration at the high level was predictive of benefit to chemotherapy, but did not enhance the predictive ability of adding trastuzumab to chemotherapy. So, this finding in itself was already different than the finding that had been reported by the FINHER investigators. We looked at the data in a slightly different way. And again, the data here are quite provocative. If we look at the reverse and we look at the patients on the left side who had lymphocyte-predominant breast cancer, again accounted for approximately 10% of patients with early-stage HER2-positive breast cancer, look at the outcome to chemotherapy alone, arm A in white, versus the outcome from RC, which is the arm of chemotherapy plus trastuzumab in terms of relapse-free survival over time. So if patients had tumors with very high lymphocyte infiltration, actually there was a trend that the patients did better with chemotherapy compared to chemotherapy plus trastuzumab, but please note that this was not statistically significant, so it is thus a trend. However, for the patients whose tumors had lower degrees of lymphocytic infiltration, there was a clear benefit for using chemotherapy trastuzumab compared to chemotherapy alone, which you see on the right graph. This was highly statistically significant. So what can we conclude from our data? Number one, increasing stromal TILs were associated with increased relapse-free survival in patients treated with chemotherapy alone. But this was not found to be associated with increased relapse-free survival in patients treated with chemotherapy plus trastuzumab. So the data in this first bullet suggests that the benefit that we saw with TILs in the context of HER2-positive breast cancer was actually very similar to what we see in the context of TILs for patients with triple-negative breast cancer. However, we did not show that increasing TILs predicted for increased benefit to chemotherapy trastuzumab. The other way to look at our conclusions is on the second bullet. Patients with non-lymphocyte-predominant breast cancer had better relapse-free survival when treated with chemotherapy plus trastuzumab compared to chemotherapy alone. But on the other hand, patients who had this high lymphocytic infiltration treated with chemotherapy trastuzumab did not have better outcome than if they received chemotherapy alone. So essentially, the message is here that for the 10% of patients whose tumors are very highly infiltrated with lymphocytes, we cannot really prove that there's a benefit to using chemotherapy plus trastuzumab, at least based on the trend that we observed in this clinical translational study. So ultimate findings, as I mentioned before, the number of stromal TILs is relevant to the benefit of chemotherapy, no clear impact on benefit to adjuvant trastuzumab. And the last part of the slide, we have our plans. Certainly, we would like to do this analysis in another cohort of patients. We want to identify the subtypes of stromal TILs that are there, because they may be helper TILs, they may be suppressant TILs. We want to correlate the presence of TILs with immune gene profiles, and ultimately, we would like to determine whether changing the amount and type of stromal TILs will ultimately help improve patient outcome. Thank you very much.